So we have two psychologists who are here going to talk to us about neuropsychological testing, and sort of this question came up a few sessions ago, and so I thought it might be useful and to invite our psychologists and talk about. I think that the principal questions were when is it appropriate to refer for neuropsychological testing, and then once you have the neuropsychological testing, what are some good ways to make use of the information that you have? So maybe I'll let you guys, and while you start talking, I'll start focusing on you so I can figure this out, so I know who's talking.
Okay, so when to refer for psychological testing. I think, speaking for myself, and this probably happens for Dr. Roche as well, one of the times that physicians or other folks will refer is when kids are struggling, obviously. They might be struggling in school, they might be struggling behaviorally or emotionally, and there's just a need maybe to know more information and flesh out what might be happening, both in terms of diagnoses, in terms of looking at strengths and weaknesses, and kind of the treatment recommendation piece. So I think if there's kind of an area where somebody might be stuck, where you know a fair amount about a child, but maybe you just want to know a little bit more, and especially kind of want to look at that diagnostic piece and see if there are other things school-wise or treatment-wise that may be helpful for kiddos. That's probably the biggest reason, kind of the biggest draw that I see patients. If you want to add to that.
Yeah, and from a neuropsychological standpoint, really looking at, again, those really complicated kids on that. So, you know, for a lot of different things. So for kids that have gone through radiation and chemo, for kids that have seizure disorders that seem to be really struggling, differentiating between attention, anxiety. Been getting a lot lately around autism and looking at, is it really autism? Is it social pragmatic communication disorder, or is it just trauma that kids have? So really looking at how trauma impacts the cognitive abilities of children as well. So I do a lot of kids with trauma, prenatal exposure to substances. And when we get the evaluations, really looking at, has the school already done their evaluation? Because insurances really will not pay. We cannot, if you submit a referral and the only thing that you're referring is wanting to look at if they have a learning disability, insurances will not pay for that because they believe that to be the school's obligation and it's not medically necessary. So if you really are looking at some learning stuff, we need to have some other diagnoses that you're kind of looking at with that. Is it an anxiety based? Is it an attentional issue? Is there some executive functioning problems going on? As the main referral question, we can look then at the learning component within the evaluations, but that can't be the only primary kind of referral question that comes in. And then once we look at that, then we can make a lot of recommendations for the school. I know myself, I believe Angela too, we do attend, or I do a lot of, individual education plans, help parents advocate for their children within that. And that is something that is not reimbursable. Billings Clinic has been amazing on allowing us to still provide that service to the community as an in-kind, because a lot of families are at the point that the school doesn't always necessarily listen to them, even though when I go to meetings, I'm really usually not saying anything that the parents haven't already said. It's just having a professional there and explaining it a little bit more to try and get the kids those services as well. So, and a lot of it's just diagnostic clarification. So many diagnoses can present the same. So trying to get really specific to try and figure out what is the underlying iteology so that we can develop a better treatment plan and help families get the resources in the community.
So maybe I'll do is I'll press with some sort of questions as to kind of to flesh out some of the things, and then we'll definitely go to Q&A for everyone else. First, in terms of things like kids exposed to substances, and probably trying to untangle. What I'm guessing is you're probably facing situations where you're trying to untangle exposure to substances versus sort of primary psychopathology. I guess what I wonder about is, number one, what sort of tests do you guys usually use? Are there some basic ones that you would tend to use frequently? And then how easy or difficult is it to untangle what sort of substance-induced versus sort of primary psychopathology?
It's not real easy, but there are some patterns for, alcohol-related neurodevelopmental disorder, the old FAE. And a lot of it really is around a lot of that executive functioning, attentional issues, a lot of comprehension. So that processing kind of issues. And so looking at that, but then we also have to have, the information that there was the prenatal exposure as well. If we believe there's all the way up to the FAS, those are where we refer off to showed error, to get the official diagnoses of that. But it's really more around that executive functioning, some of those other areas that it doesn't fit truly an ADHD profile, but there's this other kind of where it really is more around some of the processing kind of things and looking at some of that. So it's not all that easy to figure out. And sometimes I think, instead of even necessarily having, when we get to that point, an official diagnoses, to really have where are their strengths, where are their challenges, and how do we put interventions in to address those.
Right.
And so tests would be, cognitive abilities tests, looking at academic achievement, because we can sure see some impairment there, looking at attention, executive function, behavioral information from parents and teachers.
Learning profile, are they a visual learner, verbal learner? Can they repeat everything on a memory test? And so people just automatically assume that they're comprehending it as well. So we often will get these profiles where kids can repeat back a story, at the 90th percentile. But right after they do that, you ask them yes or no questions, and they're at the 5th percentile or 10th percentile. So they're not comprehending anything that's being said to them hardly at all. But people assume that they are because they can repeat back almost verbatim what they just hear. And looking at, so where's the processing issues happening? And when we look at, like for instance, reading under dyslexia, there's 3 types of dyslexia. And so giving that information to the school in regards to what intervention then and what reading program will work best based on that child's form of dyslexia is really critical, because just throwing the same thing at a child and just more of it isn't always helpful if they're not addressing that underlying processing issue and what's causing them to have the difficulties with learning.
What are the three kinds of dyslexia? Is it like expressive?
There's surface dyslexia, which is what people tend to think about, and that really is where they, reverse letters and numbers, and so they're not perceptually seeing the information correctly. And then there's the phonemic dyslexia, where it really is they see it properly, they just don't have the sounds and symbols. And then there's the mixed dyslexia, where that's the most severe, because then they don't have any way of really learning how, and so they have both phonemic and the surface dyslexia.
Got it. Now, sometimes I hear when I have schools get a report, when I get either a psychological or neuropsychological report, sometimes they don't care. Yep. They're like, well, we didn't do the testing. This isn't valid for us. So how do you get around that? Is that where you kind of insert yourself? You're like, well, I'm going to go to the IEP and advocate. Anyway, so what's your experience with that? I mean, I'm guessing you see that also.
I do see that, and that is where I go and advocate for the kid. And I try and make the recommendations doable, for the school system, that's reasonable that they can do, because schools have limitations on what they can provide and what they can't provide, and do a lot of education with the families. And if we have done a lot, then it's also working with PLUC and having PLUC representatives work with the family and be there as well, because by law, they can't say that they're invalid or they can't use it. By law, they have to consider outside evaluations as well. And so I do a lot of that and work with them.
So it's unacceptable, basically, for them to say, we can't use this. That's really it's not a thing.
That's correct.
Okay.
They can't by law.
Well, I guess it's supposed like any clinician saying, well, this person has diabetes and asthma, and then the school saying, well, we didn't do our own testing.
Right.
That really doesn't make any sense. Yeah.
Exactly.
Got it. Were you going to say something? Okay.
No.
No. So I was wondering, I was going to open up to other folks who might have questions out in the network. Anybody have questions around neuropsychological testing, how to use them, when to refer, or anything related to that?
This is Jana from Dillon.
Hi, Jen. Go ahead.
Hi, I just had a question. I've referred a couple of pediatric patients for neuropsych testing, but it's been like 3 and 4 months to get them in. So do you have any suggestions of what to do in the meantime?
Yeah, what have the referral questions been?
It's been mostly, I've had a couple of patients that I've really struggled with diagnosis as far as is it anxiety or depression or ADHD, trauma. One particular patient I know has had a difficult background, being moved around different caregivers and question of abuse. So I'm just really struggling with diagnosis, and he's really struggling in school. So I've started him on some ADHD medication, which has been sort of helpful. He's been in and out of counseling, but I really wanted the neuropsych testing to help with diagnosis.
Yeah.
Dr. Roche, because of her specialty and as a neuropsychologist, I know you're booking out farther. She's probably booking out the furthest of our psychology group. And so I think we want to make sure that that the needs are met in the best possible way. So, and obviously it depends on the age of the patient. Dr. Roche and I see the kiddos for evaluations. And so I think if there's a question of how soon does the patient need to be seen? Leanne, who does our patient scheduling, and we can sure get information out for Leanne. She may be a good person to call because then Dr. Roche and I can talk with Leanne and kind of determine in terms of working the patient in as soon as possible, but making sure that we're answering the questions. Should it be, or could it be a psychologist that, like me, that would be okay to see the patient, or, do we need a more specialized neuropsych exam? So we can kind of determine that and help you sort that out.
Okay, that's hard I appreciate that. And we're about 4 hours from billing, so it's hard for patients to travel. So that's what I run into a lot as well, is that they don't, the closest testing is 2 or 3 hours away. So even that is really hard sometimes, but it's always nice to have other resources. So thank you.
So I'm sorry, Jenna. I think all the other microphones are muted, right? Sorry, we're just getting a little bit of. Sorry, Jenna, we're just getting a little bit of feedback. I apologize. If you could just repeat kind of the last part of what you were saying. I'm sorry.
Oh, is that better?
Yes.
Mm-hmm. Okay. I was just saying it's a little tough because I have patients that they always have to travel. And so this in particular patient travels 45 minutes to see me. And so then traveling extra is really tough. It's always nice to have other resources, but getting to billings is sometimes really difficult for our patients. So,
Hey, Jana, I'm wondering, could you, so I'm guessing this patient hasn't been seen yet, right?
not by neuropsych. I think he's scheduled February.
So do you mind giving us just a few lines on this patient? So how old's the patient and what's your concern?
He is a 6-year-old little boy that came to me. He was being taken care of in Eastern Montana, actually, in Brenda, by his grandmother. And then he's now staying with his mother's cousin, who's taking care of him now. She has 3 other children, and they also have behavioral issues. But this patient in particular has severe ADHD-like symptoms. He's when he first came in, he wouldn't sit still for more than 2 seconds. He was in every drawer, not listening, not paying attention. So I ended up starting him on some ADHD medication just because he needed to be in school, and they were really struggling with him. It's helped a little bit. He's had some counseling, which has been very helpful. He's super receptive to touch and affection and care. Just
Jenna?
for him.
No, I think, Jen, I'm so sorry. I don't know. Sorry, the last like 20 seconds were just, you were doing great. So I don't know if it's the, are you on Wi-Fi?
Yes, it might be the Wi-Fi. Is that better?
Can you do me a quick favor if you don't mind? If you
Yeah.
grab a phone, pick up the phone and call this number because I want to hear this. I want it to be clear. So pick
I'll
up
try
if
to
you
type
have.
it. Let's see.
What do you want to? Can you call? Do you have a phone? Why don't you call use your office phone? Grab your office phone. That the sound will be much better. I'll give you a number. You ready? Okay. So 1-408-638-0968. Okay. Then at the prompt, you're going to tell me when you're ready. I'll give you the ID. Okay, here we go. 534-344-404 #. The code, you want the code again? Yeah, okay. Let me give you the code again. Sorry. 534-344-404. Let's see. Okay.
Okay, am I there?
Oh, perfect. Perfect.
Okay, so sorry.
That's okay.
So my patient is a 6-year-old little boy, and he is staying with a caregiver, a cousin of his mother or something like that. He has had significant symptoms of ADHD, but I question whether or not it's actually ADHD versus anxiety or trauma. He was staying with his grandmother in eastern Montana, and he kind of had the run of the household from what I understand. And he's had a really difficult time adjusting to a home where there's a couple of other kids that have behavioral issues as well. And then he's really struggled in school. So my concern with him is that I need an actual diagnosis, and I haven't been able to get him scheduled for neuropsych testing until February. So he's on ADHD medication, which has helped a little bit, but he's still really struggling.
Thanks, Jenna. So thank you. That was perfect. If just do me one quick favor, turn off the volume on your computer because you can hear it a little bit. But we could hear everything. We actually heard everything perfectly. So just that's all right. If it doesn't bother you, it won't bother us. So
Okay.
Go ahead. I think you had something to say. Go, Brenda.
So has the school, has he been referred to have any testing done at the school as far as IQ testing, academic testing, some of the questionnaires that they give to the teacher and parents, as well as classroom observation?
He's definitely had the classroom observation. Sorry, I'm trying to figure out how to turn the volume off.
And the reason I ask that is, especially when these kiddos are coming from out of town, if we can get some of that testing done by the school system, especially if they're having difficulties at school, the school should be obligated to kind of look at some of that. If they can do some of that and we get those results, then we have less to do here, and so that they're not having to be here as long. And then we can do the more specialized testing with them as well. And then we could usually get them in sooner because we don't need as much time to see them. And so in this case, if the whatever caregiver has them could request him to be evaluated by the school district, then we could get them in a lot quicker on our end as well, because we just wouldn't need as many hours to do some of the testing, and we could do more specialized.
Okay.
If that makes
Been
sense.
tough. Yeah, that does. And I think he did have something done earlier this spring in Glendive. I can't remember the exact test, but there was a question of diagnosis even in that. And then I did send the Vanderbilt ADHD scales to the school and with the caregiver, and he's like off the charts. There has been a question of some oppositional defiant disorder. However, he's really responded pretty well to counseling in that respect. So, and then they don't have a specific counselor at the school. So right now I've just been working with his teacher and trying to get him in to like have a male role model at the school to kind of help. But it's just tough when testing, it takes a long time to get them in. And then the patient lives so far out of town. That's tough. But
hey, Jana, this is Dana. I was just going to intervene for just a second. So is this a kid that lives outside of Beaverhead County?
He's in Beaverhead County, but down in Lima.
Okay, so the co-op is who Sue Osborne would go in and do the psychological testing then.
Okay, great.
And
thank you.
The other resource that's really great, it's hard for Lima because they're so far out, is to have Dorothy DeHart do a sensory processing eval. And
yeah, he's in with her already.
Okay, good. And then I've had better success getting kids in for neuropsych testing with Dr. Corey and Dr. Perry in Bozeman. They've been a little bit, they have cancellations a little bit more often than Dr. Valine.
Okay. I think that's where I sent him was Dr. Corey. So thanks, Dana.
Yeah, so it's tough.
Yeah.
Thanks.
We're working on it. He's doing better. It's just been tough. And the diagnosis piece is what I'm really struggling with. So I thought that's where the neuropsych testing would be really helpful.
Right, because when schools do their evaluations, they don't diagnose.
Right.
So they don't come up with official DSM diagnoses. They come up with their disability classifications within the school district stuff. So they're not going to give you an ADHD diagnosis or an anxiety diagnosis. Unfortunately, they will come up with autism, but their autism classification doesn't mean they meet
Have a medical
DSM
diagnosis.
diagnoses for autism. So their classification of that, and that gets families really confused. So yeah, the school, but anytime you can get the school to at least do some of the preliminary testing, it really will help the neuropsychologist as far as getting them in quicker, because there'll be less we have to do.
And it sounds like you've been working hard at getting some
Yeah.
resources in the meantime. So kudos to you.
Yeah.
Counseling and meds and
Yeah.
sensory interventions. So
Yeah.
Thank you. That's helpful, though. I'll try to see if there's anything else we can do at the school. I appreciate it.
Hey, Janet, this is Eric. Just a couple other things though too. Is I think one of the people who's best positioned to really help this kid continues to be you, and you right now have more data than anyone here. Even when they go get some testing, they're still going to rely on you a lot for a lot of the information. So I think there's some things. I think you can get a lot further than you think you can right now. So, for example, have you done because also you're qualified, Dana, to make these Jana, sorry, I'm talking about Dana. Jana. So Jana, sorry, you're qualified. Sorry, Jana, you're qualified to make these diagnoses. So I guess a couple questions. What medication did you use? How much, and how did he respond?
I started him on Concerta. I think that one was because that's what insurance would pay for. And I started him in low dose, 18 milligrams, and I believe he's on 36 now, and he's responded fairly well. He still has some behavior issues in school, but it's mostly actually with his brother, the other kid that he lives with, who also has behavioral issues. So they don't necessarily get along, but he's responded fairly well to that. It hasn't helped, I guess, as much as I would have hoped. So that makes me think that there's some other diagnoses and something else, childhood trauma or things like that, that are contributing.
Well, so does he have a history of trauma?
As the history is super unclear, but it sounds as though, yes, he does have some. He never lived with his mother, has kind of been in and out of the home as far as his mother goes. She's had multiple boyfriends, and then he mostly stayed with his grandmother, who didn't sound like she had a lot of discipline or structure for him. So he's really struggled now in a home trying to provide some of that structure.
So how far is he from Butte?
He would be about 100 miles.
Okay.
So even farther. Yeah, that's on the opposite side of us.
Okay.
So,
I was just thinking as far as Go ahead.
Oh, I'm sorry. He's really responded well to counseling. It's just been a matter of getting him in. I think he's made a lot of progress in counseling as well as the occupational therapy. He's more consistent with the occupational therapy than he is with the counseling, but he's made a lot of progress, I think, in the short term. It's just I always want them I will always want to see more progress and more success in school. So that's where I'm kind of struggling with him.
The other thing you could talk to with this related to the school is if the occupational therapist that he's working with, if that person could give the school some recommendations on like sensory breaks or other things that they could put in place at school for him. You know, can you get the, TheraBand on his, front of his chair or table, push against that. So the occupational therapist can be a really great resource on helping the school understand how that sensory is impacting him regarding his behavior and attention at school, as well as if he really is having significant behavior at school, asking for them to do a function behavior assessment as well so that they can look at what is the function of his behavior. Is it avoidance? Is it, for attention? What is his function? Because they're going to do different interventions based on that function, and requesting that to be completed by the school district with somebody trained in that would be really helpful as well.
Great, thank you so much.
And Jen, I want to continue though with also making you feel empowered to make these calls, okay? Because I don't know that because a great test, a neuropsychological testing, might come back and give you 3 or 4 different diagnoses, but you're already doing a lot of the things that would probably be recommended anyway. So I guess what I'm saying is the neuropsych testing isn't always going to be sort of the magic thing that gives you finally what to do, right? I think sometimes people expect that because they get this report and they're like, oh, this is going to tell me what to do, and it's not. And you already captured a lot of probably what's going on with this child, this kid who came from a very difficult family system, moved around, had limited sort of boundaries and structure in the home setting, struggling at home and at school, struggling with attention. So you've captured already a lot of stuff. You started the treatment appropriately. You started with Concerta. He's now on Concerta 36. And just because it's not full remission of the ADHD symptoms doesn't mean that you're not on the wrong, it doesn't mean that you're not on the right track. You may depending on how much this kid weighs, right, you could go all the way up to 1.5 to 2 milligrams per kilogram on the Concerta. Then at that point, if you've kind of maxed that out, you can then start adding some guanfacine to help augment the treatment. So again, it sounds like you've already dialed in on, based on what you're telling me, probably meets criteria for ADHD. So there's one diagnosis. ODD, make sure they meet the criteria, but what the problem in psychiatry, right, is that those diagnoses don't tell you why. They tell you they meet criteria, but it doesn't tell you what the story is. And you know the story, and you're already starting to do some of the things that are really appropriate. The occupational therapy piece is huge because all these kids struggle with a lot of sensory motor stuff, and especially as someone who hasn't been taught how to regulate himself, neither physically nor emotionally. I mean, starting with occupational therapy is a great way to do that. Does that make sense? So I think you're not doing anything different than I think I would have done here in Billings. So I want you to feel very comfortable. Keep doing what you're doing. I mean, you know, some of the scales you can monitor kind of how he's doing with some of the scales. If you guys have access to like the CBCL, which is kind of a broadband way to kind of monitor how he's doing, or do the Vanderbilt plus the SCARED scale to monitor anxiety and ADHD symptoms. So I think you have more tools than you think you do, and you probably know more than you think you do, Jana. Just saying.
Yeah. The other thing I would look at.
Thank you.
Yeah, the other thing you probably already looked at this too is how is he sleeping?
Mm-hmm.
He was having huge issues with sleep, like not sleeping at all. And I actually started him on some Benadryl, which has been super helpful. So I'm hoping with more sleep that is helpful as well.
Yes,
but
definitely.
Attention and mood.
Yeah, and I just want to say these conferences like this is so helpful, and it does empower me. So I really appreciate it. I just need that extra, like, you can do it sometimes. So I appreciate that.
But thank you, Jen. I mean, I appreciate you presenting this case and asking these questions because I think we all feel. I think that's one of the things I like about this conference too. Is I think we all, you know, this just shows we're all in the same boat, struggling with the same questions. But I've spoken to you here on another occasion. I think you have a really good sense for this work. So, you know, just keep at it. And always feel free to reach out and send an email or question if you feel a little bit stuck.
Thank you so much.
Sure. Other questions for a psychologist or about Jana's case?
This is Dana from Butte. I just had a question about neurofeedback, and obviously it is still part of the frontier treatment options, but a lot of families will come back from neuropsychological testing and ask me to give my opinion about the financial burden that they would take on to have neurofeedback, either the computer-based program that are available to them or the in-person. I just wanted to hear your opinion or where some of that research might be going.
You want to take that on, Brenda?
Sure. And I'll try to be politically correct. When I've looked at the most recent research, which has been about, to be honest, about a year ago, what it really was indicating is they looked at neurobiofeedback by itself, cognitive behavioral therapy by itself, and then combination of cognitive behavioral and neurobiofeedback. And cognitive behavioral by far did better than neurofeedback by itself. And when they did neurobiofeedback and cognitive behavioral therapy together, it did no better than cognitive behavioral therapy on its own. So that's what I know of the research the last time I looked at it.
Bill?
What's that?
Was that a thank you? I think
yes, that was a big.
Yes. Okay. Gotcha. Yeah. No problem.
Yeah.
But I think the challenge you're going to face, though, Dana, is then now, do you find someone who does cognitive behavioral therapy really well in Butte, and that might be no, but you guys have a good team, so you guys got people. What am I talking about?
Actually, we have good CBT therapists in Dillon too. We have them we have some that are in the school, and we have some that, like, Jana has Jenny in her clinic, and we have 2 CBT therapists at our clinic too. So
we have a good team.
And in Butte, you also have PCIT for the little ones,
right?
Which is amazing. Amazing.
Jana, your little person might benefit from some PCIT, but you're so far away that's an awful far distance. But I think Krista does some PCIT as well.
That's why I was asking about how close Butte was, because I know Molly there and those other ones there that do that in Butte.
Right.
Any other questions or comments? I had one more question for you guys. What's the difference between psychological and neuropsychological testing?
Well, there's gray areas. Because you can, there's a lot of tests where there's an overlap. Like IQ tests would be considered neuropsych tests, but they're also psych tests. So, there's an overlap in what Dr. Roche and I do, but I appreciate having her on board with, I guess, the kiddos that really complex neurological medical issues. I really prefer for Dr. Roche to see those kiddos.
So for example, someone with like a TBI, would that be somebody who would be a neuropsychological?
TBI, or, if there have been more like intensive medical treatments like cancer, for example, I think it can be really helpful for a neuropsychologist to really take a look at that. Kiddos where our overlap are probably what you'd consider more of the psychological issues like anxiety and depression and ADHD and autism and developmental challenges, learning disabilities. So, there's a lot of overlap, and people will call it neuropsych testing, and it might not all be neuropsych testing, but so there's some overlap, but there's some areas where I think Dr. Roche adds, even more as far as the evaluations that she does. So if there's questions about that, you can always call in, to our clinic or other places where you might refer and ask them who they feel like, who's most appropriate to see this patient, because we can help you sort that out.
And I think it also, I've heard multiple times and been taught this, that I think giving you guys good referral questions is key.
Absolutely, please.
Right, instead of saying, oh, this one needs
eval.
Eval.
Right.
Yeah. What does that mean?
Yes.
Yeah.
So, specific things that you're concerned about, the more information that we have, the better. Then we kind of know, what would be the best plan as far as the evaluation. And as, Dr. Roche mentioned earlier, we can try and expedite. There's no promises as far as, how quickly we can see patients, but the more information that we have that's coming into us, the better.
Right. And if school has done any testing, so if you guys can make sure we get records on those and get those ahead of time. IEPs, 504s, any of that stuff is really helpful to have from the very beginning.
So maybe it's like a referral question for Jana would be, let's see, is it ADHD versus trauma or both? Would be a question.
Yeah, and absolutely letting us know who else is seeing the patient, because a lot of times it might take us weeks to get information from the school, from therapists, from other folks. So if you can let us know up front, are there other folks involved with the child, then again, that can help expedite the process a little bit.